endoscopic sinus surgery and their management. I have no disclosure, no conflicts of interest. So I'm just going to start with a general overview. So around 250,000 sinus surgeries are performed every year in the US alone. Under experienced hands, minor and major complications rates tends to be low. It's around 5% for again, experienced hands, and 1% for major complications. However, the first 100 procedures performed by solo and experienced surgeons generally have a higher complication rate. Regarding revision, FESS, and complications, obviously revision surgery will have higher risk of complications because of the anatomies tends to be altered. And usually, well, at least on our experience, usually we're doing cases done by other physicians. So around 20% of patients will require a revision sinus surgery within the first 5 years after their procedures. And from those, 43% will be within the first year. So patients with increased likelihood of revision surgery are patients with polyps, AFS patients, IP patients because of the malignancy, frontal sinus disease because it's the most difficult sinus to access, CF patients, and also obesity, immunodeficiency, smoking, and female patients have been associated with a high revision rate. Legally speaking, around 2/3 of lawsuits in the ENT fields are related to the nose and sinuses. Usually what we see is CSF leak, orbital hematoma, and anosmia are the most common complications litigated. From the actual list of cases that go to review, it was found the lack of informed consent can be seen on 31% of patients, negligent technique in 76%, and wrongful death in 5%. So how to avoid complications? Well, generally you want to do procedures that you are highly trained in. It's really important that you know your anatomy and follow your own surgical technique. It depends on where you did your training. I was trained with Dr. Kentakis, and he has like this surgical steps that you follow, and I started to stick with that. And on the other hand, I trained with Arturo Solares, and he again uses like a different technique. So sometimes it's really important for you to go to different locations and do different like sinus dissection courses that you can practice and know different ways of doing it. It's really important, adequate visualization. We can discuss a little bit about that, but you want to keep a clean field, decrease the amount of blood, not only because it's going to absorb more light, but because it's going to generate more heat, so your lens is going to be fogged. Some people like to use the endoscope. I personally don't use it, but it's a good tool to have. And really important to review your CT and your MRI. And this was from this article that described the close mnemonic to address the thing that you want to see. So C stands for the Cribiform plate. You want to see your depth of your Cribiform plate according to the Keras classification 1, 2, and 3. 1 is from 1 millimeter to 3 millimeters, 2 is from 4 millimeters to 7 millimeters, and 3 is from 8 millimeters and above. To bear in mind, usually patients who are females and are obese have a lower, skull base, so meaning that they'll have a Keras type 3 rather than a type 2. So weight and a female gender will predict your depth of your skull base depth. However, the most common depth is going to be Keras type 2. The lamina, so you want to address your lamina, make sure that you don't have any, patient with a history of fractures of your lamina propria, or patient who had surgery in the past and they have some erosion of the lamina or orbital fat protrusion. O stands for Orbit&Onodi cells, so you want to look at the cranial nerve 2 and the presence of Onodi cells that you can, as you know, the Onodi cells is a cell that is the posterior ethmoid cells that protrudes back into the sphenoid sinus and can be confused as the sphenoid sinus, and sometimes the cranial nerve 2 can be exposed within the Onodi cell or even the sphenoid sinus. S starts for the sphenoid and the skull base, and usually, when we're doing sinus surgery, what you want to do is, if you're doing a full house FESS, you want to, start working from below And as you approach posteriorly and identify your sphenoid sinus, then you can go and identify your skull base and work from, like a Wigand technique when you work from posterior to anterior. So you address your sphenoid sinus going from below, and then you turn around and go back like this. And E stands for the ethmoid artery, and specifically the anterior ethmoid artery. Just to have in mind that around 60% it will be within the skull base, and 40% it will be hanging below the skull base. So it's really important that you address, especially the ethmoid artery, because this is a structure you're going to be working around really often. So how to avoid complications? So you want to make sure that you review your CT scan. In this particular patient on the right, you can see that he has some sort of previous trauma. He had a orbital floor fracture right here, and he had some exposure right here as well. The lamina is a little bit angled medially. It's a really difficult area to access right here. And also, you can see on this side, he also had like protrusion, well, not protrusion, the lamina seems to be preserved, likely the periorbital, but you have some fat protrusion right here. So this is a high risk for medial rectus injury. And on this side, you can see that this patient already had surgery, and it's difficult to see on the CT, but this patient had a skull base defect right here. So what about bleeding? We're going to talk a little bit about the most common bleeding areas, and then we're going to talk about how to control them. So vascular complications, just bear in mind that you want to have a discussion with your patient. Over-the-counter medications, sometimes vitamins and like vitamin E can impact clotting time. As experience improves, so does bleeding control. Generally, you want to have a good conversation with your anesthesiologist. You want to, we usually recommend is hypotension total IV anesthesia. It provides a very good surgical field, less bleeding. Experience indicates that prednisone should be given 7 days or more before surgery. Again, this is a really good tool to have in mind and use before you're doing any sinus surgery. We generally don't use it because we recollect data on the eosinophil count, and we don't want anything to impact our eosinophil count. So we generally don't give prednisone, but if you have a patient with bad polyp cases, like eosinophilic or CRS patient with polyps, it will really benefit from giving prednisone pre-op. Again, another medication another mix of anesthesia medication that you can use is propofol, fentanyl, and sevoflurane. It decreases the bleeding as well. You want to have a systolic blood pressure below 100, and you want to achieve a MAP around 70 around. Hypocapnia also minimizes bleeding and improves your surgical field. And some surgeons like to inject lidocaine and epinephrine into polyps. Again, we generally don't use it, but I know that it's been described. So this is one of my cases right here. It was from my early fellowship years of training. I forgot to mention, I'm trained in rhinology and endoscopic skull-base surgery, head and neck surgery, and facial plastics. And this is a case that I was doing for a lateral recess, really small encephalous heel and CSF leak. You can see the defect right here in the corner. This is the median nerve right here, and this is V2 right here, the lateral recess of the sphenoid sinus. So in this case particularly, I wanted to spare the median nerve, and I expose a little bit of the sphenopalatine artery. Well, this actually what the posterior septal artery had 2 branches, but this is the upper one. And I was trying to go around it. I've done it in the past, and unfortunately for this case, it was a tight area, difficult to see, and unfortunately you're as good as your assistant. And this, when I was working, I was doing 2-hand technique, and I wasn't paying attention to my shaft. And then all of a sudden I got this bleeding. So what you want to do in that scenario, you want to pull your camera a little bit back so you don't get any blood in it. You want to put a suction, which I was doing right there, but then eventually the scope was too close, and she basically went in there into the blood, and everything was a mess. So I kept the video this way because this is what was going on. Everybody was I was moving around and trying to get this under control. Really important to have in mind. Have your instruments ready. As you can see right here, my suction bovie wasn't working that well. I had my suction below that. It was actually the one that I was working, but this one, it wasn't suctioning, it wasn't cauterizing. So again, then you have to ask your scrub nurse to get that ready, put your suction, leave it in there, and try to stay in one place. At this moment, I grabbed the camera with two hands because I was having a little bit of a hard time working. So eventually, you know, my suction bobby started working. Well, not start working, was actually working. Then you know, I cauterize a little bit, get a little bit of that under control so I can see a little bit better. And then what I did once I had that a little bit more under control, what I did after that was to get a pledget and try to, you know, hold some pressure in with I use epinephrine 1 in 1,000. You can use epinephrine or epinephrine. So I put a little bit of pressure right there, and then I got everything ready, make sure that all my instruments were working, getting some flow seal or what we call grits, is a mix of thrombin, saline, and gel foam powder. I use the collator to just, you know, control a little bit of that vessel right there. Again, keeping your surgical field clean, your reservoir clean. You want to get all that blood hanging in there because it's going to fog your scope. And eventually, you know, I got it under control. I used the collator for this. However, once the bleeding stopped, I didn't include that, but I traced the vessel a little bit more laterally. I removed some of the posterior wall of the maxillary sinus so I can get a more proximal control, because even though the bleeding stopped, I wasn't like comfortable leaving it like that. After that, the case went really well. You know, I ended up sacrificing the median nerve, which was the thing that I wanted to do. I should have done from the beginning, but again, I wanted to spare that nerve. So what about orbital hematomas? So the incidence is relatively low, but it's really important to know how to present, what it happens, and how you can manage it, because although the incidence is really low, the impact can be significant for a patient, meaning loss of vision. So what we usually see is lid bruising and you know, like an orbital well, not a hematoma, ecchymosis, and then eventually the patient will develop proptosis. When you have a venous bleeding, the bleeding usually you know, it shows itself around 1 hour to 90 minutes. But you have an arterial bleeding, you're going to see symptoms more sooner than later. What you want to, sorry. And then just to have in mind that just 5 millimeters of blood is going to be dangerous to increase the intraorbital pressure, and you have 1 hour before you have irreversible damage and you have loss of vision. So these patients, when you have an orbital, you know, orbital bleeding or orbital hematoma, you have to take them as a level 1. So what is gonna be your plan? So usually you can see that a patient is already in the PACU and you start seeing the symptoms. So at this moment, you have to do an urgent decompression right there with the patient in the bed. You do a lateral contonomy and cantolysis, which I'm going to explain in a while. And then you take the patient to the OR and you do an exploration and possible medial decompression. If you see the bleeding intra-op, usually it's an arterial bleeding, and it's usually from the anterior ethmoid artery. And you have to be careful. If you need to sacrifice or you injure it, try to be as medial as possible, because if you go too lateral, the vessel will retract into the orbit, and that's when you're going to lose it. But I'm going to show you how you can trace it. So this is your anatomy right here. You have your lateral canthal tendon right here. You have a superior and inferior aspects of the tendon. Then you do the orchicontomy, which is basically cutting on the skin right here. You're dividing then the superior and inferior aspect of your lateral canthal tendon. Make this cut going inferiorly. So first you make the cut going laterally, and you want to feel the orbital rim. You want to get your iris scissors there. You can use a pair of Bishop pickups to retract the lid superiorly, and then you make your cut moving horizontal and laterally, and then you make an inferior cut. Then what you can do after that, you can measure your pressure, and if your pressure is above 22 millimeters of mercury, then you can go and make a superior cut before you take the patient to the OR. But at least you want to make sure that you have a really, really good release of this inferior aspect of the tendon. So if you're intra-op, or when you take the patient back to the OR, this is a cadaver dissection. You have your right frontal sinus up here, your left frontal sinus on this side. The septum has been removed, and the middle trabecum as well. I have exposed all the skull bases, the right orbit, and the anterior ethmoid artery, which is right here. So if you make your cut and you lose the vessel, you can remove your lamina, which you're achieving two goals. First, decompressing, and then tracing your anterior ethmoid artery like you're seeing right here. So you just break the bone. And again, as I mentioned before, is within the skull base in around 60% of patients and hanging outside below the skull base at around 40% of patients. But you can see that you can retract your vessel right here, and then you can get a more proximal control if you make your cut right here and the vessel retracts and you lose it in there. When you have a venous bleeding, is really a little bit more straightforward. You can do a direct cauterization. Obviously, be careful. You don't want to get a suction bovie close to the skull base or the anterior ethmoid artery. But you have venous bleeding around that area, you can use it with being careful about those structures. You can use hemostatic agents like flow seal or gel foam. Again, we generally use gel foam powder with a mix of saline and thrombin. Or you can do simple packing with Afrin or epinephrine pledget, saline irrigation. Ideally, you want to have it at 40 degrees heated, so it can help with hemostasis, and you can use bipolar incove later. If all this fails, you can always do packing if the lesion or if you don't have any intradural defects. What about the carotid? So this is an image of a cadaver. Again, you have the sphenoid sinus exposed right here. This is the sella right here. The paraclival carotid right here. The petrous, I'm sorry, not the petrous, the cavernous portion of the carotid right here, and the paraclival, paraclinoidal process of the internal carotid artery. You have your lateral OCR and your medial OCR. And usually this area right here is either thin in 20% of cases or absent. And sometimes you can have an intersinus septation that it will point towards your carotid right here. So usually really close to this paraclinoidal process of the carotid. So we have talking about carotid artery bleeding. The incidence for sphenoidal surgery is really low, it's 0.4%. However, when it can happen, and for skull base a little bit higher. We recently reviewed a case of a carotid injury after balloon sinuplasty. So just to bear in mind that it can happen. The morbidity is around 24% and mortality is around 14%. And also, like I mentioned before, you have the carotid bulging into the sinus as well, around 4% of patients. So how many patients will have a stroke after an internal carotid sacrifice? Usually around 25 to 30% of patients can have a stroke after that. Most of them have collateral circulation. And when you are doing some balloon occlusion tests, specifically for petrous apex lesions that you have, for example, a chordoma, and you're doing a balloon occlusion test, even patients who pass a balloon occlusion test can have a stroke, and it can happen between around 10% to as high as 30% of patients who already pass a balloon occlusion test, but can still have a stroke. So when you get a bleeding from the carotid artery, well, it's really easy to say than done. Try to keep calm. You want to use double suctions. So you want to have two suctions in your hand. You want to so you can have a clean feel, because the blood is going to pool really fast. So you want to use either a 10 French or a 12 French suctions, and I mean two of them. You want to get a pledget and apply pressure to it. And while you're applying pressure to it, you have one of your assistants to grab a piece of bone. I'm sorry, not a piece of bone, a crushed muscle. And it can be either from either side. At this moment, it doesn't matter where you grab. You can grab from the deltoid, you can grab from the leg, but you want to get a piece of crushed muscle. The NASBS usually every year has a simulation model. If you go to that meeting, try to stop by. It's a really good experience and a good training that you can acquire there. So after the bleeding is controlled, the patient should be taken to the angio suite and do an angiography to make sure that you don't have a pseudoaneurysm and the bleeding is controlled. And in the worst case scenarios, you have to do like a endovascular permanent occlusion of the internal carotid artery. What about neurologic complications? So it can be secondary to vascular damage, like an orbital hematoma, direct injury to the olfactory nerve, olfactory fibers. Again, anosmia can happen. So it's really important that you discuss that with your patients, that patient can develop anosmia after sinus surgery. The optic nerve, and you can have the optic chiasm injury as well. It can be direct or indirect. Direct because of a direct lesion with a cutting instrument, or from bleeding and pressure from it. The recovery rate is very low. However, patients can recover when you have like an indirect lesion, not a direct lesion. And also, you want to have a discussion with your patient about video nerve injury. So what about CSF leak? The rate of CSF leak is related to the extent of the disease. Usually for endoscopic sinus surgery is around 0.4%, and for skull-based surgery is going to be around 7%. Again, it all depends on the location of your lesion, but usually it's on the anterior ethmoid cavity between, against the middle turbinate medially and just posterior to the frontal recess and the anterior ethmoid artery, which I'm going to show right now. Usually around 82% are related to image guidance systems. So just to have in mind that image guidance is not going to protect you from having a CSF leak. And as I mentioned before, the lower the depth of your skull base, the higher chance of you having a CSF leak. So just bear in mind that female and obese patients have a lower skull base, like Keras type 3. And some surgeons recommend leaving some tissue between the turbinate and the skull base, just to avoid getting really close. So again, this from a video, an image from this cadaver that I showed you before. Just going back, this right frontal, left frontal, the septum in the middle, which has been removed, and the turbinate has been removed as well. But I just want to show how the orbital plate of the frontal bone is a really hard bone. You can see I'm using my J-curve and I'm putting a lot of pressure, but if I go to a lateral lamella of the cribriform plate, I can easily fracture it. So again, orbital plate, lateral lamella, and you can puncture through it really easy. And if you're using cold instruments, I'm just showing you can peel that bone really easily without getting into it. So I personally don't like using the microdebrider in this area, because I use it myself sometimes, but I don't like when a resident or a fellow are using it, because I don't have any control of it. So I start staying away from it. But I would recommend when I'm doing teaching of residents and fellows, I just generally recommend using the J-curve in this area. If you stay close to the right side, to the orbit, you're not gonna get into any trouble. And if you break the lamina a little bit, it's not gonna be the end of the world. But you don't want to use any power instruments in this area between close to the orbit or close to the lateral lamella of the cribriform blade. So this is a case that I wanted to show. It's a 40-year-old African-American patient with a history of facial twitching and nasal obstruction. This is a patient that I was called to assess because of an intraop CSF leak. The CT scan showed a left nasal cavity mass that appeared in the cribriform plate. In nasal endoscopy, was reported that they showed a left firm, regular, non-friable mass. So, this is some of the CT scans from outside. They noticed a unilateral mass, so they ordered an MRI. The MRI didn't show anything like specific. There was a little bit of a image here that it could be considered like a possible defect, but it wasn't. Oh, sorry. It wasn't like 100% sure that it was a defect in this area. This is the read from the MRI. There was no evidence of intracranial of intraorbital extension of the lesion. So this is a video of the surgery. This was the mass. Again, it wasn't friable. There was no leak at this moment. So the surgeon that was doing the case just decided to do a biopsy. So he, addressed along the skull base right here. There was attachment to the superior nasal cavity and the lateral nasal cavity. So he took a sample of it, and I'm sorry I didn't mention that. I was going a little bit fast, but it was reported as a possible enterochoanal polyp. So they did the biopsy, removed the mass again using power instruments right there. They sent it for PET, and the PET didn't show anything specifically other than a polyp and some benign inflammatory mucosa. And that's the reason I like to do intra-op biopsies, because you want to get a good sample. So anyway, so at this moment, they were using the microdebrider, and then they noticed something irregular. That's when they call me, and then I noticed that oh, sorry, there was this mass right here, and you can see right here a CSF leak right there. So this is what you usually see. You see like the halo sign, that you have that clear fluid in the middle and blood around it. So at this moment, I removed some of the mass to get a little bit more exposure, and this was our defect. And you can see clearly here the leak right there. So I harvest an inferior turbinate mucosal graft. Reconstruct this. Once you see this protrusion right there, you want to use your bipolar, or you can use Coblator. At this moment, we thought we were dealing with encephal seal, so I used the bipolar to shrink the encephal seal a little bit. Then I start scraping the mucosa circumferentially, and I use an inferior turbinate free mucosal graft. This was a low flow CSF leak, a small defect, so I felt comfortable with using this. It will be enough to control our defect. So again, you want to make sure that you have a really packed in there, going circumferentially, remove as much mucosa as you can, and then put a little bit of gel foam in the middle to keep it in place. I don't recall if I used TZIL. I think I did for this case. And this was a week post-op. And then we did a revision case and removed the remaining of the mass. And no CSF leaks 6 weeks post-op. This is the area where I harvest my graft on the right nasal cavity, the inferior turbinate graft. And the path from the first surgery showed basically, some polypoid sinonasal mucosa and benign arachnoid meningeal proliferation, but nothing specific. And then the revision, the path review showed that it was a meningioma, but everything went really well. We removed all the tumor out, and the patient is doing really well. No leak after that, and the tumor is controlled. What about infections? Infection can be systemic or local infections. Between endoscopic sinus surgery it depends on if you have a CSF leak or not. The risk of meningitis after a CSF leak is going to be around 20%. You want to avoid unnecessary stripping of the mucosa and avoid exposing any bone. What about extraocular muscle injury? So the right eye tends to be a greater risk than the left, and I think it's because most of the surgeons are right-handed. It can cause strabismus and diplopia. If fat is exposed and you need to finish the case, one thing that you can do is do some gentle bipolar of the orbital fat, and that will make it retract a little bit so you can see a little bit better. It's really important to know how to differentiate orbital fat from intranasal contents of polyps, because it can lead to irreversible damage and complete loss of vision. So so you can have in mind, here you have your medial rectus muscle. And usually when you're working the anterior ethmoid cavity, you have a little bit of like a fat buttress. So you're going to see fat before you see muscle. However, the most common areas of orbital, the medial rectus muscle injury is going to be around the area of the basal lamella, which is the vertical portion of the basal lamella, or the posterior ethmoid cavity, because you're not gonna have any fat there to protect your muscle. So like, as you can see in this case, in this junction where the basal lamella was supposed to be, you can see a clear defect here, the lamina propria, and the continuity of the muscle has been lost. And I don't know if you have seen this case, really impressive case of 42-year-old patient who came in for like standard sinus surgery, no visual problems in the past. The outside provider, ENT OpNode, mentioned that he used the microdebrider to remove some uncharacteristic appearing polyps, thought that he was in the maxillary sinus until he noticed an ophthalmos, and this was the result. The patch showed basically orbital contents and some sinus tissue. The oculoplastic nose, it mentioned that the entire globe was exonerated, basically. So this is a really, really, unfortunate but bad outcome. Is really important to see how like a really standard procedure can go really bad. Scarinized Synechia also can cause complications. Um, as you can see here, it is not a short-term complication, but it can be a long-term complication, like this patient right here, that he had a chronic sinusitis with bilateral mucoceles, and he underwent sinus surgery, but he had a complete sinus surgery, so the frontal recess wasn't completely addressed and completely open. Basically, the frontal sinus scarred, and he had two fistulas right here on the right and on the left side. This is a case that I did that I'm going to present in a meeting. Inverted papillomas are associated with a 30% chance of mucocele formation when they're in the frontal sinus, and additions post sinus surgery can cause nasal obstruction, recurrent CRS, and require revision sinus surgery. Pneumocephalous is a uncommon complication, but it can happen. Usually, not usually. When it's uncomplicated case, it can be managed as an expected managed with rest and 100% oxygen. However, the majority will require some surgical repair. There's a case from Delgadio that shows a really large 1.5 millimeter defect of the skull base. And I'm sorry, not 1.5 centimeter defect of the skull base with a really impressive pneumocephalous. So I just want to make some quick notes about image guidance. Image guidance improves your outcomes when compared to non-image guidance surgery. It decreases the rate of recurrence and improves nasal symptomatology, and also improve surgical time. However, there's no difference in complication rates between IGS and non-IGS groups. So the most important thing is knowing your anatomy, what instruments to use, and your own technique. So conclusions: just follow what you feel comfortable with. Follow your steps and your technical rules, your surgical technique. Know how to manage these complications. Know when to ask for help. It's better to be flush 2 times or 3 times in your life rather than the rest of your life. So if you need help from your ophthalmology, oculoplastic, neurosurgery, or endovascular surgery, don't feel bad about asking for help. And it's really important that informed consent that mentions the risk of orbital and brain complications, specifically loss of smell and vascular injury, if the sphenoids that enter it are necessary and need to be documented. And that's my talk. If you have any questions, I'll be happy to answer them. If you have any more questions along the way, here's my email, and please stay in touch. Thank you. All right.